Good afternoon, ladies and gentlemen. Thank you for inviting me here to present some of our work. So, is radiomics the future for post-traumatic stress disorder management? Well, the programs that we have been working on is the capacity to assess soldiers with PTSD, blast injury, head injury and chronic pain, and I'd like to thank Doctors Helen Cartledge, Amanda Toman and Teresa Keane, who are our program managers from the Australian Army, CTTSO, USA and the Australian Special Operations. And I apologise for my voice, it's just coming back. So in the past, when you go to the doctors, you're actually treated using evidence-based medicine. So however the previous 3,000 people have responded or have presented, you'll be judged and treated accordingly. But that's not so easy when it comes to conditions like PTSD, blast injury, chronic pain, because while they have the odd individual descriptor for the psychologist or the psychiatrist, they also have a whole series of common effects. So what we're trying to do is we're trying to develop magnetic resonance, particularly spectroscopy, to develop a precision medicine approach to health, disease, and degeneration. And I'd like to share some of that with you today. It's a multinational approach, and what our common goal is to understand brain biochemistry in vivo using two-dimensional magnetic resonance spectroscopy and multimodality magnetic resonance imaging. And it is providing a new insight in how our brain chemistry operates, changes with degeneration and with disease. And what we are finding out is that abnormal brain chemistry changes the way we feel and how we behave. This is a Siemens clinical research scanner. There are currently 2 in Australia. The first one was in Newcastle, and that's where the data that I'm going to show you for PTSD was collected. We hope to have one operational in Brisbane shortly. Equally importantly, and I'm going into this detail because some of this has been tried overseas with the technical capabilities, not what they might be. My colleagues at the Martinez Center at Harvard Medical School have been designing the head coils. And this is what they look like in the research stage, and then this is what they look like when you actually go into one of the clinical scanners. So one-dimensional magnetic resonance spectroscopy is a combination of individual chemical species that actually superimpose on top of one another in the one-dimensional spectrum. So there is quite a wealth of information present, but because they overlap, it's difficult to interpret. What we've done over the last 10-year period is to develop two-dimensional spectroscopy. So it's a bit like pulling it out in a second dimension, and in our case, it's a second magnetic frequency. So it actually allows us to separate out these neurochemical moieties. We can look at it in a couple of different ways. This particular one is possibly the easiest way. And what I'm going to show you, this is, I promise, the most detailed chemistry I'll go into, is how we can actually interpret this. This is actually a fat spectrum. And if you follow the ABCs, you'll see that each of the letters I show you allow us to trace with exquisite detail through this entire molecule, which happens to be a triglyceride molecule, a fat molecule. But we can do this with every one of the neurochemical species in the brain that are mobile on the MR timescale, and that is the important component. We don't look at DNA or RNA or any of the rigid molecules. We look at the ones that are mobile on the MR timescale, they are related to disease, to inflammation, and when these pools arrive, we know that there's something taking place. So we have a series of imaging metrics that we actually utilize in each of these studies. Standard magnetic resonance imaging, the 2D spectroscopy I'm about to explain to you, functional magnetic resonance imaging, so we can actually see how the brain is changing when tasks are being undertaken. This was developed by our colleagues at the Martinez Center in Boston, and it's their protocols that we are using, and they will be analyzing this data. This is diffusion tensor imaging. This shows us how the neurons are actually in the brain, and if there are any damage, we can actually identify those and link them with a disease process. And last but not least is susceptibility-weighted imaging, which is very important to the warrior, because this actually allows us to see, and if you can see the little black holes in the brain, they are actually the effect of blast injury in this case. So let's start with the healthy brain, because we really need to understand the biochemistry of the healthy brain. So here's a one-dimensional spectrum with the 35 different chemical species, and now if we look at the two-dimensional spectrum, and I just want to work through this and show you some of the important components of this that we're now in a position to measure. So the little blue box you see in the top left corner of this 3D plot, I'm going to show you over the next couple of spectra. And this is a very recent assignment and piece of work, but it's turned out to be quite important. These are molecules known as fucosylated glycans, and they have been shown to be involved in neuronal processes, learning, development, memory, neurite growth, and neuronal morphology. We just made the assignments in vivo. The Caltech people have actually shown these in animal models to actually be involved in learning, development, and memory. But what we are also now recognizing is that some of these molecules, these fucosylated epitopes, are involved in the very early events of inflammation in the brain. So the Caltech group are doing some very detailed animal studies, and they're looking at these molecules as being involved in glycocoding. So let's just move on to the damaged brain now. While we were at Boston at the Brigham and Women's Hospital, had a visit from Boston University and from the National Football League in the United States. And those of you that have been listening will know this is an even more hot topic, because there is actually a movie going to air at Christmas time that the Football League over there are trying to ban. We had a visitation from a group of young men. They were Harvard graduates, but they'd all actually played what we know as gridiron or NFL over there, and they knew they weren't quite right, and they wanted to do something about it. And they also recruited some of the older NFL players, some of whom had lost so much executive function, they had difficulty flying across from California into Boston to actually get in the scanner. And there's a rather sad history here, because this really started to come to the fore as people like John Grimsley were committing suicide. And these people, they were shooting themselves in the stomach, not in the head, so that their brain could go to the brain data bank in Boston to prove that there really was something wrong with them. So the Boston group were undertaking histopathology, and the white tissue on the left is healthy brain from a much older person than Grimsley, and the right is from Grimsley's. And you can see the staining there shows there to be amyloid tangles. This is diagnosis after death. So the question that was put to us, could we actually do this while these people were alive and provide an objective method of diagnosis and potentially a means to heal? This isn't just for football players, it's for anybody who is in combat, a warrior, jockeys, ice skaters, football players. And in this country, we've had several jockeys have commit suicide from exactly this phenomenon. It's known as chronic traumatic encephalopathy, but in reality, it's repetitive head injury. And I'm not going to spend time analysing the spectra, I'm just going to tell you the results. And I can tell you, in this group of people, the phenylalanine in their brain was raised by a whopping 46%. And we know that phenylalanine interferes with the production of serotonin, which influences mood and leads to depression. The fucose, which I just described to you, increases by 60%. So we know that neuronal development, learning, and memory is being affected, and it's probably involved with some form of inflammation, which we now are in a position to check. The glutamate increased by 31%, and we know from animal studies when glutamate gets to a certain level, it actually causes neuronal damage. And the choline increased by 65%. This is an indicator of brain tissue damage, and let me just say the error bars on these is 3%. So with Brian Ross at Caltech, we've actually been now looking at targeted interventions for repetitive head injury, for example, anti-neuroinflammatory treatment or anti-phospholipase treatment, or ways of decreasing glutamate in the brain. So now let's move on to the disturbed brain. And I should point out that the human brain is thought to continue to develop until we're about 25, 26 or 27 years of age, which means that impact in the adolescent years or the early 20s is going to have quite severe consequences for people. We know that chronic pain alters brain chemistry, and I'm going to describe that in a moment. And we know from a rat model that continued stress alters brain biochemistry. And I'm going to show you today for the first time it also alters the brain chemistry in those suffering from post-traumatic stress disorder. So it was in the 1990s that Michael Cousins from the University of Sydney, Michael's probably accepted as being the world expert in chronic pain management, sat down by me one day and gave me a nudge and said, "Do you know there's no objective test for chronic pain?" Which of course I didn't. He said, "Well, can we develop one?" And so we did. With our two teams working together, we found that we could actually put people with chronic pain in the scanner and undertake the technology that I described to you, and with very, very high accuracy, we could determine whether they had chronic pain or not. You can actually see that in this spectrum, the glutamine is actually, and glutamate is increased. While, again, we were actually in the United States, we worked with the Draper Laboratory. The Draper is a spin-off from MIT, which is funded by the US Department of Defense, and we worked with their rather sophisticated informatics people. And we found that we could develop classifiers, so my team wasn't left reading it ourselves, because we couldn't be on every scanner around the planet. We could actually have classifiers for an automated diagnosis. But what came out of this was a little bit more than we had anticipated. We found that the level of biochemical degradation with chronic pain, particularly with chronic pelvic pain, actually allowed us to identify some of the specific molecules involved. And fucose was indeed one of those molecules. Here we can actually see that chronic pelvic pain type 2 has extremely large changes to the fucosylated glycans, but it also has a very high level of free fucose in the brain. Now, if you think that the enzymes that normally modulate the fucose, the fucosylated glycans in our brain, are normally very tightly controlled, all of this free substrate is going to cause an enormous amount of confusion for these people. Moreover, the Draper people showed us that they could use the levels of these fucosylated glycans to actually determine the level of pain that these people were undergoing. So now I want to move on to our very early results for post-traumatic stress disorder and acknowledge my team on the left-hand side, led by Dr. Scott Quadrelli, and our collaborators in the United States and in Australia. The data was collected on the Prisma 3 Tesla clinical research scanner in Newcastle, and we have ADREC approval. So right now we have some early data from our PTSD cohort and very early data from our blast injury. The MTBI, I've already expressed some of that data for you. That was collected in the United States. These are the clinical metrics and the neuropsychological evaluations. And Scott is with us in the audience, and I'd like to acknowledge Sandy McFarlane, who helped us, from Adelaide, who helped us establish these. So on the left-hand side, we have the 2D spectrum from the PCG of a typical healthy control, and on the right from a patient with post-traumatic stress disorder. And you don't need to be a rocket scientist to see that there's some very significant differences here. Moreover, the size of these differences is really quite large, quite startlingly large. There is a very significant increase in lipid in the brain of these PTSD sufferers. And even though it's a small number, we're up to n equals 4 right now, they were all the same. I think that's what blew me away. I expected there to be different levels of these changes, but there's not. So here's a table. The size of change is really quite staggering. Again, the error bar for this head coil is 3%. And I'm not even going to try and interpret what this means right now. But I am going to go through it, and there's a couple of these molecules that we can comment on. We do see an increase in glutamate at the expense of glutamine, and we also see a change in the fucose. I'm going to talk about fucose first. So this is the fucose region from a healthy control, and this is the fucose region from a PTSD sufferer. And the fucose 1 and the fucose 3 molecule is gone. Now, this is quite different to what we saw in the chronic pain patients. So what appears to be occurring now is that the neurochemical fingerprints for repetitive head injury, PTSD, and multiple types of chronic pain, neuropathic pain, nociceptive pain, and neuroinflammatory pain, they're all different. Oops, try and go back here. So the glutamine and glutamate, this has always been difficult in vivo to distinguish between, but what we've actually found with those is that in the PTSD patient, and I think this is going to start for us, yes, thank you, we can actually see that it is the glutamine levels that are going down and the glutamate levels that are increasing. And this is, in fact, what we saw in the NFL players with repetitive head injury. And there was quite a significant amount of neuronal damage in those with repetitive head injury. Now, we know that this particular region of the brain is linked to spatial memory and discriminative avoidance learning. So we seem to be supporting the hypothesis that the PCG mediates the interactions between emotion and memory as part of what's going on. The fact that we see an increase in lipid supports a report about that fatty acid amide hydrolase has been linked with arousability and aversive memories in those with PTSD. So where does this leave us? Well, we know that the diagnosis, an objective diagnosis, is now possible. We need to collect sufficient data to develop robust classifiers that can actually be inserted into the clinical scanners around the world. And Siemens Healthcare have agreed to do that. They've just made the Translational Institute, Research Institute in Brisbane, an innovation and translation centre for Australia and Southeast Asia, and they have actually agreed to fast-track this technology to a product. Now, the other thing that we've been thinking through are targeted interventions, and two early possibilities are anti-neuroinflammatory treatment. There are several FDA and TGA approved drugs, and also amantadine treatment to counteract the increased levels of glutamate in the brain. The other possibility using this technology is that we can actually monitor each individual and they are their own control. So we can monitor, if somebody's diagnosed with PTSD, we can actually monitor them during these potential therapies to see if in fact they are responding to treatment. I'd like to give you a working hypothesis now going forward, and this is not just for PTSD, this is for all neurological diseases, whether it be deregulation or damage. And that is that there's going to be multiple syndromes associated with all of the damage and diseases that we have discussed. And each individual is going to have a range of what we call diffuse axonal injury, or DAI. PTSD is going to be a combination of those. Not every PTSD sufferer may have them all. They may just have some of them. And as long as we can identify what each of these deregulations are or the damage is, then each individual should be able to be treated according to precisely what is not working properly. So I'd like to look at the best way forward for the health of the soldier. My recommendation to the Army is that they install the appropriate MR scanner at one of their deployment bases, that they recruit some MR radiographers who will be trained in these latest protocols. They scan all soldiers as part of their regular medical. They scan all new recruits at the commencement and every 6-month period. They scan all special ops before and after deployment. They scan the breacher instructors and those being taught at the start and the end of each course. Because if there's one thing I learned after a trip to Holsworthy, the special ops people think they should have a special control cohort, and once I understood their exposure to blast, I totally agree with them. And then I think we should scan symptomatic soldiers along with the conventional testing. So we're also now in a better position to answer how early changes to neurochemistry can be recorded following battle. Are some warriors more susceptible to slow or no recovery? And I think that's really what we were hearing with the last speaker in relation to epigenetic effects. Is the highly trained soldier more able to withstand or recover from damage? I think that question can be asked now. Is the damage cumulative in some or all people? And I remember when Michael Cousins first asked us to work and develop a diagnostic test for chronic pain, he said to me, Carolyn, people can take chronic pain for so long, and then the body somehow goes into a loop, a biochemical loop that it can't get out of. And he says, that's what I'm faced with. How do I actually break that loop? And I believe that PTSD, in part, has the same problem. Knowing which chemicals alter with the stress, the pain, etc., we have to ask, can we actually provide prophylactic treatment? And does this reduce the effect? Does everyone with increased phenylalanine in the brain experience depression? And can this be tested? Is the soldier with the altered neurochemicals like fucose, phenylalanine, glutamine capable of functioning optimally in battle? And can the soldier's own stem cells provide the most effective treatment? And I also would like to look at the ethical consequences of what we're now doing. And I've got a small story. So after we had started looking at repetitive head injury at the Brigham, I think when they asked us to do it, they thought, oh, never going to do it. And two things happened when we did this. The older NFL players put it on their websites. There really is something wrong with me. It's been proven. And that was really important to them. To the young NFL players who were around town holding down top jobs, it was, oh my goodness, what if our bosses find out? So you've got multiple ethical issues here to consider. I know that the generals want to know, are their soldiers affected because they don't want to send them to battle? A, it will make it worse for them, but B, can they actually respond appropriately while they have abnormal neurochemistry? So I'm a little different to most people in the room. I actually don't think about the names that's associated with each of the conditions I've been speaking about. What I actually think about are the individual biochemical pathways that are broken, and is it possible for us to now use the information that we have to try and fix what's broken, or at least to ameliorate it to help each individual carry out a more normal life. And this is the new PTSD team. As we've only been in Boston now since February. We're now working together with the local PTSD teams, and very much looking forward to getting some more interesting data. I've just been told that the Australian Army is going to take over our project from the terrorism section, and I'm looking forward to working with them. And if you would like to contact us, that's my email address, and that is Scott Quadrelli. We are finding that we're not recruiting people with PTSD as quickly as we would like to, and any assistance to help us with recruitment would be gratefully accepted. Thank you.